This recording will go over venous thromboembolism. Venous thromboembolism, or VTE, is one of healthcare's greatest challenges and includes both thrombus and embolus complications. A thrombus is a blood clot believed to result from an endothelial injury, venous stasis, or hypercoagulability. Deep vein thrombosis, or DVT, is the most common type of thrombophlebitis. It is more serious than superficial thrombophlebitis because it presents a greater risk for pulmonary embolism. With PE, a dislodged blood clot travels to the pulmonary artery, a medical emergency. DVT develops most often in the legs, but can also occur in the upper arms as a result of increased use of central venous devices. Thrombus formation has been associated with stasis of blood flow, endothelial injury, and/or hypercoagulability, known as Virchow's triad. The highest incidence of clot formation occurs in patients who have undergone hip surgery, total knee replacements, or open prostate surgery. Complications of immobility occur during prolonged bed rest, such as when a patient is confined to bed for an extensive illness. People who sit for long periods of time, like on an airplane or at a computer, are also at risk. Phlebitis associated with invasive procedures such as IV therapy can also predispose patients to thrombosis. In terms of assessment, assess the patient for a history of any type of VTE. In addition, assess him or her for risks that may be associated with the development of VTE, such as prolonged periods of sitting or bed rest, recent surgical procedures, or any factors that may affect coagulation. People with DVT may have symptoms or may be asymptomatic. The classic signs and symptoms of DVT are calf or groin tenderness and pain, and sudden onset of unilateral swelling of the leg. Pain in the calf on dorsiflexion of the foot, a positive Holman sign, appears in only a small percentage of patients with DVT, and false positive findings are common. Therefore, checking a Holman sign is not advised because it is an unreliable tool. Examine the area described as painful. Compare the site to the other limb. Gently palpate the site, observing for induration or hardening along the blood vessel and for warmth and edema. Redness may also be present. The preferred diagnostic test for DVT is venous ultrasound. MRI may also be used. A D-dimer test is a global marker of coagulation activation and measures fibrin degradation products produced from fibrinolysis, clot breakdown. A negative D-dimer test can exclude a DVT without an ultrasound. A positive D-dimer test would indicate that a DVT is possible, but it wouldn't be the only test used to diagnose a DVT. Because D-dimer basically is associated with the D-dimer test is associated with clotting. So let's say you have a post-op patient who thinks maybe they have a DVT because of whatever their signs and symptoms are. Depending on how recently their surgery was, D-dimer may be elevated just because they had recently had surgery. So again, negative rules out DVT. A positive D-dimer would be indicative of the possibility of a DVT. The focus of managing thrombophlebitis is to prevent complication such as pulmonary emboli, further thrombus formation, and an increase in the size of thrombus. Patients with DVT may be hospitalized for treatment, although this practice is changing as a result of the use of newer drugs. In terms of non-surgical management, DVT is usually treated medically with a combination of rest and drug therapy. Prevention of DVT and other types of VTE is crucial for patients at risk. For those at moderate to high risk, initiate these interventions to prevent VTE. They include patient education, leg exercises, early ambulation, adequate hydration, graduated compression stockings, intermittent pneumatic compression such as sequential compression devices or SCDs, venous plexus foot pumps, and anticoagulant therapy. Supportive therapy for DVT has typically included bed rest and elevation of the extremity. However, research shows that ambulation does not increase the risk for pulmonary embolus. The risk for pulmonary embolism associated with more aggressive activity is unknown. The accepted approach is a gradual increase in ambulation as tolerated by the patient. Allowing patients to ambulate may decrease their fear and anxiety about dislodging the clot and life-threatening complications. Teach the patient to elevate his or her legs when in the bed or chair. To help prevent chronic venous insufficiency, instruct patients with active and resolving DVT to wear knee or thigh-high sequential or graduated compression stockings for an extended period. Be sure to select the correct stocking size for the patient according to the sizing chart provided. Some healthcare providers prescribe intermittent or continuous warm, moist soak to the affected area. To prevent the thrombus from dislodging and becoming an embolus, do not massage the affected extremity. Monitor all patients for signs and symptoms of PE, which include shortness of breath, chest pain, and acute confusion. Emboli may also travel to the brain or heart, but these complications are not as common as PE. Anticoagulants are the drugs of choice for actual DVT and for patients at risk for DVT. However, these drugs are known to cause medical complications and even death. Some patients with a confirmed diagnosis of an existing blood clot are started on a regimen of IV unfractionated heparin. The healthcare provider prescribes heparin to prevent further clotting, which also often develops in the presence of an existing clot, and to prevent the enlargement of the existing clot. Over a long period of time, the body slowly absorbs the existing clot. Before heparin administration, a baseline PT, APTT, INR, CBC with platelet count, urinalysis, stool for occult blood, and creatinine levels are required. Notify the primary healthcare provider if platelet count is below 100 to 120,000 depending on agency protocol. With the patient receiving heparin, APTT is measured at least daily, and results are reported to healthcare provider as soon as they are available to allow for adjustment of the heparin dosage. Therapeutic levels of APTT are usually 1.5 to 2 times normal control levels. Notify healthcare providers if the APTT value is greater than 70 seconds, or follow hospital protocol for reporting critical lab values. Assess patient for signs and symptoms of bleeding, which include hematuria, frank or occult blood in the stool, ecchymosis, petechia, and altered level of consciousness or pain. If bleeding occurs, stop the anticoagulant immediately and call the healthcare provider or rapid response team. Heparin can also decrease platelet counts. Mild reductions are common and are resolved with continued heparin therapy. Severe platelet reductions, although rare, result from the development of antiplatelet bodies within 6 to 14 days after the treatment begins. Platelets can aggregate, forming an acute arterial occlusion. The healthcare provider discontinues heparin administration if severe heparin-induced thrombocytopenia, a platelet count less than 150, occurs. Low molecular weight heparin is used more commonly today because of the complications involved with unfractionated heparin. Highly selective direct thrombin inhibitors may be used as alternatives to heparin for patients who have had heparin-induced thrombocytopenia. Like heparin, these drugs increase the risk for bleeding. Ensure protamine sulfate, the antidote for heparin, is available if needed for excessive bleeding for the patient who is receiving heparin. Please review Chart 36-7 on your own, which reviews safety and quality care and best practice for the patient receiving anticoagulant therapy. To prevent DVT, unfractionated heparin may be given in low-dose sub-Q for high-risk patients, especially after orthopedic surgery. Alternatives to unfractionated heparin include low molecular weight heparin. Your prototype low molecular weight heparin is enoxaparin. Novel oral anticoagulants. Your prototype is apixaban, and also warfarin. Subcutaneous low molecular weight heparin, such as enoxaparin, have a consistent action and are preferred for prevention and treatment of DVT. Enoxaparin does not require routine APTT tests like heparin. If the patient is receiving continuous heparin, Warfarin, an oral anticoagulant, may be added. The warfarin is taken at the same time the patient is receiving the heparin so that the warfarin can accumulate enough in the body to have a therapeutic value in the body, or a therapeutic serum level in the body. According to the National Patient Safety Goals, therapeutic levels of warfarin must be monitored by measuring the INR at frequent intervals. Most patients receiving warfarin should have an INR between 1.5 and 2.0 to prevent future DVT and to minimize the risk for stroke and hemorrhage. For patients with additional cardiovascular problems or pulmonary embolism, the desired INR is higher, up to 3.5 or 4. For patients taking warfarin, assess for any bleeding, such as hematuria or blood in the stool. Ensure that vitamin K, the antidote for warfarin, is available in case of excessive bleeding. Report any bleeding to the healthcare provider and document in the patient's health record. Teach patients to avoid foods with high concentrations of vitamin K, especially dark green leafy vegetables. These foods interfere with the action of warfarin, which is a vitamin K synthesis inhibitor. The latest development in anticoagulation is the use of novel oral anticoagulants such as apixaban. These medications were developed to have fewer drug interactions and a wide therapeutic index to allow for fixed dosing without the need for frequent laboratory monitoring. Thrombolytic therapy using catheter-directed approach can be used. However, anticoagulant therapy is preferred for most patients with an uncomplicated DVT, reserving thrombolytic therapy for extensive DVT. A deep vein thrombosis is rarely removed surgically unless there is a massive occlusion that does not respond to medical treatment and the thrombus is of recent onset, 1 to 2 days. Thrombectomy is a surgical procedure for clot removal. Pre- and post-op care is similar to that of the patient undergoing arterial surgery. For patients with recurrent DVTs or pulmonary emboli that do not respond to medical treatment, and for patients who cannot tolerate anticoagulation, inferior vena cava filtration may be indicated. The surgeon inserts a filter device in the femoral vein or jugular vein. The device is meant to trap emboli in the inferior vena cava before they progress to the lungs. Holes in the device allow for blood to pass through without interfering with the returning blood of the heart. Post-op, after a patient has received a filter, after surgery, inspect the groin insertion site for bleeding and signs or symptoms of infection. Other post-op nursing care is similar to that for any patient undergoing local anesthesia. Please review Chart 36-8, Food and Drugs that Interfere with Warfarin, and please review the final section, Care Coordination and Transition Management, on your own.